Hi, everyone. I think we're going to get started here. My name is Sarah Zangle, and welcome. I really appreciate everybody joining in. I'm honored to host here. I am a nurse anesthetist in the U.S. I live in Pittsburgh, Pennsylvania, and I work at a tertiary care facility. And I've been a practicing nurse for about 15 years now. So very excited to be here with you all. Very excited to be talking through Hemafuse and the life-changing medicine and experiences that it's giving people around the world. And just here to welcome you to the fourth webinar in the series Saving Lives with Auto Transfusion Lessons from the Field. This is a CSU global webinar series where clinicians are able to speak about their experience using Hemafuse in surgery and other global health issues. Hemafuse is a medical device that operates on the principle that your own blood is always better than someone else's. In surgical cases with internal bleeding, Hemafuse captures pooled blood within the surgical site, filters it, and connects it directly to a blood bag. And then that allows the same patient to receive their own blood during that surgery or immediately afterwards. Today's webinar will focus on the key role that the theater nurses really play in the successful implementation of Hemafuse at a public hospital in Kenya. As it's shown on the screen, our program today will consist of a presentation from our featured speakers, a short demonstration of the assembly and operation of Hemafuse, and a panel discussion and open question and answer session. We are so excited to be joined by our two guest speakers today, Miss Hellen Mwai and Miss Jane Onyari. Hellen and Jane will be speaking about their personal experiences using Hemafuse in their hospital and in the OT, the effects of Hemafuse that has had on them in their profession and also on their patients and the staff there, and the methods that the nursing staff have used to implement Hemafuse so successfully. Also today we have Emma Muraguri, Hemafuse Training Executive at AMREF Health Africa. Emma brings a great deal of Hemafuse expertise to our program today, and she will lead us through a short demonstration on Hemafuse, how to operate it, and just its uses. And that's following our first presentation. After the Hemafuse demonstration, we will proceed to a panel discussion with Helen, Jane, and Emma, and then we will open it up for a Q&A session. For the Q&A session, you can either submit questions via the Zoom chat during the webinar, or you can use the raise your hand function to ask your questions. We do ask that you keep your questions during the question and answer section to clinical questions relevant to patient care and focused on the presentations specifically that Helen, Jane, and Emma give. The Hemafuse stock is currently available in Kenya and Ghana. Any inquiries about availability, pricing, purchase orders, some of the more administrative things can go directly to Tim Goodwin, and his contact information is posted in the Zoom chat and also will be on the screen later in the webinar. Thank you for your attention, and I appreciate that. So first, we're going to start with Hellen and Jane. It's my pleasure to introduce them as the featured guests of today. Hellen Mwai is a specialized critical care nurse currently coordinating services in the operating theater and reproductive health department at a level 5 hospital in Nairobi, Kenya. Her passions are in prompt management of surgical emergencies and achieving good outcomes with good quality of life for the patient. Hellen holds a Master's of Science in Nursing and is a PhD candidate. Her PhD is focused on acute kidney injury on postoperative patients. Jane is joining us as well. Jane Onyari is a Kenya Nurse Council certified practitioner. She has practiced as a clinical nurse for over 15 years. She has 7 years of experience in perioperative patient management. She has a passion for reproductive health, and for the last 2 years has been a part of the team that saves lives through the interrupt use of Hemafuse. Hellen and Jane, would you give us your presentation and your insight into how Hemafuse has helped you guys so much?
Thank you, Sarah. And hi, everyone. You're most welcome to this presentation. My name is Hellen. I want to start by giving you a background on how Hemafuse was introduced in our hospital. This is in the year 2018, and we got to know about Hemafuse when apparently we were holding a mortality meeting. And in this mortality meeting, we noticed that our patients could not make it because we didn't have enough blood, and it was also not transfused timely when it was available, and we could not save the patient. When we were doing this mortality meeting, one of the participants highlighted to us that there's a device called the Hemafuse, and we went ahead and asked the person, how did you hear about this? And told us heard from a CC representative who was just a call away, who was able to come to a hospital the following day, introduced herself, was received very well by the administration, and from this point, introduced us to Hemafuse. So from the year 2018, we have basically grown from that year. We have learned how to use Hemafuse. We have appreciated the advantages. We have faced challenges on this Hemafuse use, but basically it has been a device that has been able to save lives in our patients. It didn't come so easily because none of us was trained by then on how to use Hemafuse, and training has to take place. How did training take place in our hospital? The Fuse Global field representative made appointments with the hospital, was able to be given a schedule on how to train people, and being a very committed person, had to hold CMEs that involved almost everyone in the hospital. So almost everyone in the hospital had an idea that there is Hemafuse, and we had to concentrate on the surgical team. From the surgical team, we were all trained, demonstrations were done. With every demonstration, everyone present for that CME return demonstration had to be done. And this gave us hands-on effectiveness on how to use this Hemafuse device. Return demonstrations really helped almost everyone in my department, in the operations theater. Every member of the team was also very free to share the challenges it's getting in using the device. So by the year 2019, the whole team knew how to use the Hemafuse device. And everyone who was coming in had to adopt the system of knowing how to use the Hemafuse. That is how we got to learn how to use the Hemafuse. And with the training, we had supportive supervision, and this was done frequently by the CISU Global representative. He was always in our theater, was always checking on who has challenges in using the device. We could share how we are using it, and we appreciate our administration because they held our hand. They gave us time to learn, and they appreciated the work we were doing. There's also retraining that was going on, that after every 1 month, everyone had to retrain. Everyone had to retrain. This was so easy because by then, everyone was well acquainted on how to use the device. So when the retraining came, we were just sharpening our skills on how to use this device. And this was so good because by the time we went to the table to use it on our patients, it was all success stories. That is how we learned to use the Hemafuse. Now, as the nurses working in operating theater, we have roles that we play, and the major roles played by the nurse could not go without mention, because the nurse played a very big role to ensure that this Hemafuse device is being used for the correct patient without delay, and it is there on time. And I would allow my colleague Onyari to talk about the role of the nurse on Hemafuse hard device use.
Thank you so much, Helen. Good evening, everyone, and welcome to our meeting. Welcome to the webinar. And we are so hopeful that you'll be able to learn something out of it, as we are going to share our experiences in the field. Yeah, I'm going to talk about the role of the nurse when it comes to the use of the device. When a diagnosis has been made from the outpatient, from the accident and emergency department, Usually they call theater to inform us that there is a patient and a theater list is brought. And it happened that this theater list is being received by the nurse. So once you see the diagnosis on the list, and in most cases, we get ruptured ectopic pregnancies or abdominal injuries, but a high number of patients that we receive to theater who are candidates of Hemafuse ruptured ectopic pregnancies. So once you've identified that the diagnosis of the patient is qualifies a candidate to have Hemafuse device used, then it's the responsibility of the nurse to organize for the availability of the apparatus. Usually it's taken to CSSD for sterilization. Immediately you organize for it to be brought, and then you ensure that it is in good condition, it has not expired and all that. And also during this particular time, while you're still organizing on that, while you're organizing on the patient to be brought to theater, you check on the lab works. By the time the list is brought to theater, the staffs in accident and emergency, they will have done blood works. You're able to see the HB of the patient. At times you find that the HB is low, but most of the time you can find that the HB is normal. It can be 12, but depending on the condition of the patient, you can be able to categorize this patient as one that you can be able to use the device. And now, as you organize for the operation now, preoperatively as a nurse, it is your responsibility to inform the other staffs, because theater is a teamwork. We have got the nurses, we have the doctors and the anesthetists. So it's good also to inform them that we're having a patient being brought in for this kind of, for exploratory laparotomy with an ruptured ectopic abdominal injury, and then ensure that the team is acquainted on how to use the device, and also have a lead person in the person who will be able to guide the whole team in harvesting blood. And so with that in place, you'll be able to, by the time the patient is brought to theater, you'll be able to have all your gadgets ready, and even the set that you're going to use during the operation. And also, in case some of the team members are not competent to use the device, as Helen has mentioned, we've been having continuous training for staffs. So it's good to have someone who is competent in using the device to guide the whole team for in order to have a successful operation, and in order to be able to harvest enough blood. So having said that, intraoperatively, what is the role of a nurse? So as you scrub in, as you prepare all the instruments for operation, you ensure that you set your trolleys before you go to the operating table. You have to assemble the accessories. This Hemafuse comes with a number of accessories, which if you don't have the idea on how to assemble them, you will not be able to harvest blood. So it's the responsibility of you, the scrub nurse, to have the accessories in place, and also to be able to put them in a way that you'll be able to have a smooth procedure. And once you are on the operating table and an incision has been made on the patient, it's now, we have got, usually the surgery is conducted by 3 people. We have got a surgeon, an assistant surgeon, and a scrub nurse. And also the 4th is the anesthetist, who will be doing the blood transfusion as the surgery is ongoing. So the surgeon will be controlling the younger tip. The younger tip, Emma will show us during the demonstration. So as the surgeon controls the younger tip in a way that it is not inserted too deep to injure the patient's organs or tissues. And also, it should not be on the surface of the blood, because if this happens, air will accumulate and you will not be able to harvest enough blood. And now, once the surgeon holds the younger tube, the scrivener, the assistant surgeon, is the one who controls the plunger. The plunger is a device that looks like a big syringe. You'll be using it to suck blood from the abdomen. And then the third person, who is the scrub nurse, is the one who will be controlling the stop cock. The stop cock is in a way that when you harvest blood into the plunger, and now you are releasing it to the blood bag, the third person will be releasing air. Once air is over, will be allowing blood to the blood bag. And with the continuous procedure, once a blood bag is full, you'll hand over it to the anesthetist to transfer the patient. The process is repeated, and it's a smooth process, because personally I've done it more than 20 times, because we encounter a high number of ruptured ectopic pregnancies in our facility. Like in a week, we can conduct like 4 to 10 cases, but even at times we conduct 4 cases in a single day. So once you feel like the blood that you have harvested is enough, you just then continue with the procedure. Now, the role of a nurse post-operatively. Now, this is a patient who has received autologous blood. What is your responsibility as a nurse in theater post-operatively now? You will have to monitor this patient in a recovery unit. But so far, we've not had any complications associated with the auto transfusion. Every operation that we've conducted and a patient who have received autologous blood transfusion have come out successful, and it is a plus to us, and it really encourages us and gives us a reason to be able to conduct more surgeries. So you as a nurse in the recovery unit, you ensure your records are updated, and just in case of any eventualities, you are able to get your records straight. Yeah, so mainly that's the responsibility of a nurse, right from before you receive the patient, before you begin the surgery, during the surgery, and after the surgery. Yeah, and after that, of course, we've got some positive changes that have taken place as a result of Hemafuse use. Before this Hemafuse device was introduced to our facilities, we really had challenges of getting blood, and most of the surgeons used to be so skeptical in conducting surgeries, because you feel like these patients will have to need to benefit from blood transfusion, and now you don't have blood, but at the same time you will have to conduct the surgery, because definitely you need to stop the bleeding from where it's coming from. But a challenge comes post-operatively. You've done your surgery successfully. Now, what happens that now you don't have blood to transfuse the patient? Now, from the introduction of Hemafuse, patients have been able to benefit, especially patients with the rare blood groups like rhesus negative patients. They have been able to benefit from their own blood, and it is something which is really so wonderful about this Hemafuse. And also the issue of scarcity of blood in the county and in the country at large, that used to affect the outcome of the patient after surgery, has been able to be addressed, because even if you are told there is the blood is not available for a specific patient, and you have the gadget to use to collect blood for that specific patient, then you are able to you just have to take in the patient and you do your surgery successfully. And also from the time of introduction of Hemafuse, the period of recovery of patients are shortened, because you can imagine a patient who needs blood transfusion, but has gotten that blood intraoperatively. The time this patient will spend in the hospital versus the time the patient will spend if he or she was waiting for blood transfusion in the ward differs. So from the introduction of Hemafuse device, the time that patients spend in the ward, the period that the period taken for the recovery of the patient is as shortened, and patients are able to be discharged home within a short time. And this has really relieved the relatives of the cost of paying for inflated hospital bills, because when you look at a scenario whereby a patient has been taken to the ward, but she needs blood transfusion, you know, this patient will stay for a very long time in the ward waiting for blood transfusion. And remember now, the hospital bill will be accumulating as the patient waits for blood. So this has also been addressed by the introduction of the Hemafuse device. And also intraoperatively, the time that is taken to conduct a surgery has really shortened. And this has really made us conduct many surgeries. The number of surgeries that we conduct lately versus the number of surgeries that we used to conduct before the introduction of Hemafuse is really different, because lately, once you get a patient, you already have what you need. You have got blood at hand. The surgery moves smoothly, and within a short time, you are done. So this gives allowance for us to be able to do other surgeries, and it provides also space for others, other operations to be conducted. And also, patients have really given testimonies. Others have given testimonies on how they have benefited from autologous blood. And I believe it is what has really contributed to us handling a high number of patients lately. Hemafuse it's really a major transformation as far as patient recovery is concerned. And I could add that every public or private health hospital could embrace this device and be able to save lives by use of it. It's an essential device that should not be missed in any hospital setup. And also, one of the advantages, part of the advantages that have been brought about by the introduction of device is that since the patients receive safe blood, the number of comorbidities related to low blood levels, like severe anemia, heart problems like congestive cardiac failures, these cases have really reduced tremendously. And also other patients who need allogenic blood, who need blood transfusion, those who are who cannot benefit from autologous blood are able to get blood from the lab, because at least our lab nowadays are equipped and they have enough stock to transfuse to patients. Mainly, those are the benefits that we've been able to see during the use of the use of Hemafuse device. I now welcome Helen to talk about the supportive system, because as much as we've been able to do this, as much as the patient, and for us to be able to have the smooth running of these procedures, there must have we have supportive systems that are really enabling us to be able to handle our patients in a smooth way. Welcome, Helen.
Okay. As Jane has said, it has been successful with the use of Hemafuse, and this has not been without effort from every team that is participating in patient care. The support system has been tremendous, and the continuous training and demonstrations that have been done by the CSU Global representative was one of our major highlights. because this was one of the things that made sure that everyone in theatre was comfortable in using the device. The supply of the device has also been in a speedy supply. That means every patient that wanted to use the Hemafuse device, we could have the device and in good condition to use the device. Sorry. The hospital management was always on our back. It's always around the external people from the city global and from AMREF also to join our theatre. They were never denied access to our hospital because they knew that they were doing a course that would really improve on our patient care. The supportive supervisor by the field officer has been very continuous, and with the trainings and the return demonstration that took place, everyone in theatre, led by the nurse, this is a thing that has been done by the whole team. The surgeons, the anesthetist, the nurse, and everyone in theatre know how to use the device. Those people who are not very competent in it could always tell a person who is very competent in this, please be the team leader in harvesting the blood. With the support of the team leaders who've been there in theatre, the team that was coming in, maybe someone is coming in from leave, someone is coming in from another department, the team leaders and the people who had the who are holding the mandate of making sure that everyone knew how to use Hemafuse could gain the access of Hemafuse and the effectiveness it could use with ease. So we thank CZ Global, we thank AMREF, we thank our administration for the support that we have given all three. However, it didn't come without challenges. Number one, there's a very high staff turnover, especially on the nursing side. You get that your staff who are leaving the department and the staff who are coming in. And since we're committed in saving the lives of patients, we are committed in making sure that blood is transfused if needed using the Hemafuse device. Trainings continue. This was a major challenge, but we immediately had to sit down as a nursing team. We immediately had to consult with the surgeons. We had to consult with the anesthetists on who needs training, who is the new person coming, and this has really helped us overcome this challenge. New people are still coming, but we are still training and retraining. So this is a process that is continuing, and we don't see like we're going to edit again one time, because the advantages of using the device have basically impacted a very big, it's a very big impact in our hospital. As Jane has said, I would just like to highlight patient safety and patient recovery has made us go on and had made us use the device more and often. Thank you.
Thank you so much, ladies. That was lovely. I think it's great. Not having known much about Hemafuse prior to this, I'm congratulations on your huge success with it. It's amazing that you've been able to get better outcomes for patients, faster surgeries. You know, it sounds like it's become standard procedure for you there, which is great. It sounds like it's not too difficult to learn how to use, although you do have the staff turnover. I feel like that's everywhere right now. Everyone is just, I feel like you train somebody and just as fast as you train them, they're out the door. So I'm glad that it's not too difficult to use, that you know, that you guys are able to continue to use it and able to continue to keep training people. And it's also nice that the resources are there online to be able to train people online too. So with that, we're going to learn how to use it. So thank you once again to Hellen and Jane. And next up is Emma. So I want to introduce Emma Muraguri. Emma is the Hemafuse Training Executive for AMREF Health Africa. She holds a Bachelor of Science in Nursing from the University of Nairobi, a postgraduate certificate of Health Professions Education from Maastricht University, and is currently pursuing a master's degree in public health from the University of Nairobi. Emma brings over 10 years of academic and professional expertise into human resources for health training to her work on Hemafuse. And she will now demonstrate for all of us how Hemafuse is used to salvage and transfuse a patient's own blood back to themselves.
Thank you, Sarah. My name is Emma Muraguri from AMREF, Kenya Country Office. Thank you for joining us today, everybody. And I hope this video will answer any questions that you may have about how the Hemafuse is used to provide life-saving autologous blood transfusion immediately during or after surgery. Right. So Hemafuse can be used with minimal adaptation to existing surgical techniques. As you can see here, the operating team can still remove large clots or particulates by hand from the abdominal or thoracic cavity or wherever the pooling of blood may be. The Hemafuse filter is 170 micron and is very effective at trapping smaller clots and contaminants. However, large clots still have the ability to clog the Yankawa tip or the Hemafuse filter and should be removed by hand. So you only need 3 surgical team members to operate the Hemafuse. 1 to pull and push the plunger, and 1 to operate the Yankawa tip, and 1 to operate the stopcock. So in this demonstration, the Yankawa tip is being wrapped with a gauze. So this is a protective measure the surgical team take to prevent small clots from clogging the Yankawa tip. So first, the Yankawa tip navigator will insert the tip in the middle of the pooled blood. Then the Yankawa tip navigator will want to avoid inserting the tip too deep and coming into contact with tissues or organs, injuring them, as you would with normal suction. And they also avoid placing the Yankawa tip on the surface of the pool of blood because they want to avoid aspirating air. So once the tip is inserted in the pool of blood, the team member operating the plunger will begin to pull back slowly, as you can see in the video. So as they pull back on the plunger, blood will pass through the filter and enter the collecting barrel. So once the plunger is pulled back to the level of the autoclave tip, the team member operating the plunger will stop pulling back. So at this point, there's mixture of air and freshly salvaged blood in the collecting barrel. So Hemafuse has the ability to allow the surgical team to easily release the air from the barrel using the stopcock or 3-way valve, as you can see there. So communication is between the team is very, very critical here. The plunger operator must operate the stopcock, must let the stopcock operator know when they want to release air from the collecting barrel so that the stopcock can be positioned to release air from the Hemafuse system. So once the air is released, the team members will confirm that they are ready to fill the blood bag with freshly salvaged blood. So by pushing the plunger downwards, blood will make its way from the barrel directly to the blood bag. So it is necessary to push the plunger, to push slowly the plunger at this point. So how Hemafuse is engineered, it's engineered in a way to limit the amount of pressure that can be exerted on the blood, and this prevents hemolysis of the red blood cells. So pushing any faster will not cause the blood to enter the blood bag any quicker. Okay. So the blood bag is pre-filled with the citrate anticoagulant, and the stopcock operator will gently rock the blood bag so that the freshly salvaged blood can mix with the anticoagulant. So once the bag has been filled with blood, the team will communicate to release air out of the blood bag. So if necessary, and then they'll disconnect the filled blood bag from the system. So the autologous whole blood will now be ready for transfusion back to the patient. So blood collected via Hemafuse is viable for retransfusion to the same patient for up to 6 hours post-collection without the need for refrigeration. So if need be, a new empty blood bag, once again pre-filled with citrate anticoagulant, can be connected can be connected to the Hemafuse, and the team can continue salvaging blood that has pooled internally.
Thank you so much, Emma. We appreciate that walk through the demonstration. I would like to begin a panel discussion with our three guest speakers, and we're going to start off actually with Hellen. Hellen, how often do you see patients with severe bleeding or trauma come to the hospital? What's a typical day? What's a typical week? And what's a typical month?
Thank you, Sarah. In a week, we can have 4 to 8 patients requiring auto transfusion.
Are most of those ectopic pregnancy ruptures?
Yes, most of them are ectopic pregnancies that are ruptured and fluidity. Remember, by the time this patient reaches to us, has stayed for some time. You know, when you get an ectopic pregnancy, it really takes some time before you get to know the real diagnosis. So most of the time they have internal bleeding for some time. By the time they reach to us, they already have some internal bleeding. Their blood levels have deteriorated downward. And by the time they're reaching to us, having a Hemafuse to transfuse, it really a plus for them in saving their lives.
Yes.
The same as those patients who come with abdominal injuries. Those who come with abdominal injuries, they're not a big percentage, it's a very small percentage. But the fact that this is an acute thing that has happened, for example, it's an accident, for example, it's a fall, this happens without preparedness to the patient or to the hospital. And due to the high use of blood in our country, we all know that having to auto transfuse has been a plus in saving patients' lives.
Thank you very much. Jane, this next question is for you. I know that we had discussed that you see ectopic pregnancies a lot, ruptured ectopic pregnancies a lot, and that's mostly what you take to the operating theater. What is the typical trajectory for a patient that's coming with an ectopic pregnancy? What state are they coming to you in typically?
Most of the patients that we handle with the ruptured ectopic, their conditions is usually alarming because, as Hellen said, by the time even the theater list is prepared, this patient will have gone to other facilities. This patient will have stayed in the accident and emergency for some time. So we handle patients who are in a critical condition. So that's why we're really grateful for the person who really invented this device, because it has been able to save lives of these patients.
And what is, Jane, this one is for you as well. What is the availability of donor blood in your hospital usually, typically? Sorry, or Hellen, whoever wants to answer it.
Okay. It's a challenge. Having blood always available in the blood bank is a real challenge. So having an option of auto transfusion, the team feels safer. They feel if we don't have this blood, we don't have to worry much if the conditions allow we auto transfuse. Because as we all know, in our country, like where we are working, the blood bank distributes blood to the whole country. And by the time you get blood to be stored in your blood bank, waiting for a patient is very difficult because the number of patients who are waiting transfusion is also large.
Thank you so much. I really appreciate it. I had a couple other questions just out of my own curiosity, because I work at a facility that sounds quite like yours. We receive a lot of obstetric emergencies at our facility, including surgical obstetric emergencies. So we do a fair amount of ruptured ectopic pregnancies as well, and in addition to other things on the obstetric unit. So one of the challenges that we are facing right now is here in Pittsburgh, Pennsylvania, in the US, is that with the advent of COVID, blood is very, very difficult to come by. Not as many people are donating for a lot of different reasons. Fear of going out into public, into medical facilities when they don't have to. Also, so the donation the donation piece of it is falling off. And then also people need more blood just because of the nature of COVID, and then everything else is still happening, right? Ectopic pregnancies or ruptured ectopic surgeries are still happening every day. But then COVID is taxing the need for more blood transfusion. So clearly the need for blood is out there. And currently I was at work last night. We have 2 days worth of blood availability for our patients right now. So, you know, if we are not able to secure any more donor blood by Friday morning, it's morning here right now, by Friday morning we'll be out. So I can definitely see the value of a product like this. So my follow-up question is that I think this is mostly for Jane, because you had talked about how you prepare and the role of the nurse going into surgery when you get the call there's a ruptured ectopic pregnancy in the emergency department. Is Hemafuse a standard thing that you open when you're preparing your operating table, or is it something that you decide once you've seen the patient and seen the condition of the patient, like you had said before, seen the labs and all of that? So I don't actually see Jane on here any longer. So maybe Helen, you could answer that question.
Okay, the use of Hemafuse is not something that you're very sure you need before you open up the patient, because there's the conditions that give you go ahead. But this blood is, the conditions that you check that this blood should not be contaminated with either gastric content or food or any other content from the internal abdominal walls. Yeah? So what happens in our setup, you just have to make sure, as long as you anticipate the patient might need it, make sure that you have everything available in the operating theater. You don't just open it from the packaging, but you always make sure that it is there. When the surgeons and the team who's operating open and decide that now conditions are favorable and we can harvest this blood, what you just need to do is open up your kit and harvest. You don't have to waste time now to go look for the bag or go look for the plunger. Preparedness. You make sure that operatively you're prepared with everything that you need.
Thank you very much. I appreciate it. And where is it kept in your hospital, and who makes the decision? Can anyone in the operating theater make the decision that, hey, I think we need to use Hemafuse? And does everybody know where that's kept and that sort of thing?
Okay, the Hemafuse, the device itself is autoclavable for a number of times. The one you're having at the moment is 25 times. So immediately it's used. The parts that are supposed to be autoclaved will go direct to the central sterilization unit. The blood bags and the blood bag and other connections, they are single use. So those are available in our stock center in theater. Everyone in theater is aware of the protocols we follow to need to do the procedure. The device has to be availed from CSSD immediately. That is the sterilizing unit. And the blood bag and the other connectors has to be availed from the store in theater. So everything is basically within reach. And everyone in theater, right from the surgeon to the anesthetist, all of them has an idea on what it is they need for the transfusion.
How did the change happen in your operating theater from the way that you used to do it prior to Hemafuse to the way that you do it now, where Hemafuse is a standard procedure for you, basically standard operating procedure. You're quick to turn to it. What did that change look like, and how did that look for your hospital?
Number one, we all know that we learn at different levels, so we had to hold each other's hands. I appreciate the team that we're working with in theatre, that everyone, right from the surgeon, the anesthetist, and the nurse, worked as a team. We all worked as a team. There was sometimes we could doubt, will it work, will it not work, when we were actually touching it. But the first few cases that we did, it was success, and this is what gave us confidence.
Okay, so you saw it work, and you thought, okay, this is now.
It was very new to us. It was very new to us, and when we did the first case, the first surgery, and it succeeded, it gave us confidence, and we saw the outcome of the patient.
Okay, great. Thank you so much. We are going to begin to open up the question to answer to everyone here. But before we begin, we just wanted to remind everyone to please keep your questions clinically focused. We're going to ask questions to Emma, Helen, and Jane if we get her back on the line. The Hemafuse stock is currently available in Kenya and Ghana. And any inquiries about availability, pricing, purchase orders, those sorts of things can be directed to Tim Goodwin. And his contact information is displayed on the screen now. And then it's also posted in the Zoom chat as well. So I appreciate your attention and I thank you. I have the first question for Emma. There has been a lot said about the advantages of using Hemafuse. What are some of the dangers involved?
Unmute. Great. Thank you, Sarah. And again, thank you so much to the audience and Joshua in particular for that question. So yes, we've talked about the advantages. What are the dangers? How I tackle this is to look at the contraindications, because with any intervention, you have the indications and contraindications. So using Hemafuse during these stated cases can pose a danger to the patient. And when you look at the contraindications, we categorize them into two. The first is absolute, where we should never ever use Hemafuse if the patient presents with any of these. And this includes things like sickle cell anemia, because sickle cell anemia, giving a sickler the same blood poses more harm than good to the patient, because of course we know the morphology of the sickled red blood cells. You also have malignant tumors. There's a risk of now the cancer spreading to other parts. We have bacteria. It can introduce septicemia if the bacteria was local at the area where the blood was pulled. You also have bile, irrigated solutions, and amniotic fluids. These three things can cause lysis to the red blood cells. Again, we know amniotic fluid, if it has contaminated the pooled blood, you want to avoid using because of red blood cells lysis, and also because of risk of embolism. So that's the first category of absolute, do not use Hemafuse. The other category is relative. So this will be at the discretion of the surgical team, particularly and they can decide they'll weigh the benefits versus the prevailing condition. So these are things to do with impaired renal function. You have uncured bone cement, foreign matter. We have if hemostatic agents were used prior to pulling the blood. You have gastric fluid in the pooled blood, and if there's any suspected systemic infection and coagulopathies. Thank you.
Okay, thank you very, very much. It looks like we have Jane back as well, so that's welcome back. Also, I think this question is also from Josh. We're going to ask Helen, is Hemafuse used in situations only to do with ectopic pregnancy, or is it applicable to all other surgeries where blood can be collected while the surgery is going on?
Thank you, Sarah. No, it's applicable to any other surgery that, as Emma has told us, if there are no contraindications, for example, abdominal injuries, you can use the Hemafuse. All you need to do is the surgeon and the team that is doing surgery has to assess the blood before we have it, and give a go-ahead that the blood is not contaminated. You can have it, and immediately give to the anesthetist to continue with transfusion.
Great, thank you so much. This question is for Emma. How are people trained on the indications and contraindications for Hemafuse?
Right. Thank you, Sarah. So basically, for facilities where the Hemafuse is placed, they usually get a comprehensive training that looks at the indications, the contraindications. The training also comprises of a bit of introduction on auto transfusion, how to assemble the device, as well as how to use it. Again, we do have the content online, and this is something that can be available for health workers who are interested in learning about auto transfusion and Hemafuse.
Thank you so much. We have another guest joining us today. His name is Tim Ernest Ofosu Apaya. He's a consultant anesthesiologist from the University of Ghana Medical Center. And if he is interested, I would like to invite him to be able to briefly discuss Hemafuse in Ghana, if that's possible. Tim, are you here and available? I'm going to ask one other question while we track Tim down and see if he's still available for us. Oh, okay. When he is available, we will go ahead and talk to Tim about his experience. But I did want to ask, is there a way that so in my job, sometimes during routine surgery that we're not anticipating any bleeding and we have regular suction going, you know, and our blood loss is anticipated to be, you know, 20, 30, 40 mL, something like that. And all of a sudden it becomes more than that. In our culture here, the surgeon sometimes does not admit to the excess blood loss initially. I don't know if that's part of your culture there in the OT, but sometimes it becomes a little out of hand quickly. You know, they hit a blood vessel that they weren't anticipating or something like that. In that event, oh, hi, do we have Tim?
Hello, yeah, this is Ernest here.
Hi, welcome.
Yeah, thank you. Yes, we have taken delivery of some Hemafuse sets, but we were reserving it as a pilot to use for ectopic pregnancies, ruptured ectopic. Unfortunately, since the pass got to us, we have not done any of such surgeries yet. So we haven't started using it, but as soon as we do get cases, we will start using it.
And you are the lead anesthesiologist at your hospital, is that correct?
Yeah, yes, that's correct.
So when you are there in the operating theater, are you one of the decision makers in terms of when the patient should be getting blood versus other interventions?
Yes, that's right.
Okay. Okay, great. So this might actually be quite beneficial for you as well, because it sounds like it's a bit faster. I know for us requesting blood, typically
because we've used other self-salvage devices in the past, and Hemofuse, I'm sure, will be very beneficial. Unfortunately, we haven't used it yet, but we will use it to help us.
Okay, great. We look forward to hearing how it goes in the future.
Okay. All right. Thank you very much for having me on the webinar.
Thank you for joining us. I have one other question for Emma, and either Helen or Jane can jump in to this question as well. So what I was leading up to is that when we need to change trajectories in our OR to okay, this procedure has gone from a routine amount of blood loss to much more significant. For us right now, we don't have an auto transfusion, autologous transfusion blood option unless we call in something called Cell Saver, which for us to activate Cell Saver would be about a 2-hour process. So we'd have to call the specialist in, they have to set up the machine, they have to then prime the machine and begin harvesting the blood. And clearly that's not going to be very effective if when we start bleeding, it's a 2-hour time to service. What is let's say you do not have Hemafuse, you weren't anticipating on having to use it. Let's say you're doing something like, I don't know, an appendectomy. Let's say that, an appendectomy, and the surgeon accidentally hits an artery and you have some bleeding and somebody says, okay, maybe we can use Hemafuse here. What is the time from, yes, we would like to use Hemafuse to we can have the Yankauer in the patient and start to be evacuating that blood? Either Jane, do you want to start to comment on that, or Emma?
Yeah. Okay.
Sorry, Jane. We'll have you go first. Jane, do you want to comment on that as somebody that's in the field in the OT calling for that setup?
Yeah. Okay. I'd like to come in that because in our facility we use the device like every day. So in the morning when we report, part of the instrument that we get from CSSD to theater is the Hemafuse device. So in case of an eventuality or in case of a change of the procedure, immediately that you feel that you are the patient will benefit from Hemafuse use, you just have to call for the apparatus to be brought to the operating table, and you harvest blood. So we do not have that period of waiting for the instrument or waiting for the device, or because we already have everything in place, because we use it like daily. It is rare really to finish a week without using Hemafuse device. So that's for us, it doesn't take us long to change from whatever that you are using in case maybe a surgeon has hit a major vessel and you want to harvest blood. Immediately, you just call in you ask the circulating nurse to bring in the device and you're able to continue the procedure.
In the morning, how long does it take to set up without, I know that it takes some setup. How long does it take to set up without, I know that when you're already operating, it's already set up and ready for your use, because you will eventually use it at some point. In the morning, when you're prepping it, how long does it take to set up?
Our hospital is a 24-hour operating hospital. So in the morning, if you report and you find that maybe the staffs who are night duty had not maybe used the Hemafuse device, maybe if it's in the CSSD, it just takes 10 to 15 minutes to have everything ready for you to be able to be in the procedure for the day. But if it is let's say there is an ectopic pregnancy, an erupted ectopic, the patient is supposed to be to have been brought before maybe the day shift staff's report. that means the staffs who are on night duty will have brought the device in the theater. So we do not have that lapse of maybe waiting for instruments for a long time, because our CSSD is just a step away from theater.
If I ever get a rupture ectopic pregnancy, I'm going to come to you.
Oh, yeah, sure, definitely.
You are a prepared woman.
We were prepared because we do have, we do manage a lot of those cases in our facility.
Yeah.
Actually, more than 20 even in a week.
Wow.
Yeah.
Are there any other questions from the audience that anybody wants to put into the chat? I think we've had a wonderful, wonderful session in terms of thank you so much for sharing your experiences with Hemafuse. Emma, thank you for teaching us how to use it and giving us those resources. We appreciate everybody. It's one thing to see a device and think, oh, that might be good to use or might increase patient care, and it's quite another to see people in the field doing it and saying this really works and this is a good option for your facility too, because it changed the way we do things. We appreciate everyone for attending, and thank you to everyone for joining us today for this installment of Saving Lives with Auto Transfusion. We really appreciate it. Join in for the next webinar series. There will be another one to follow. And thank you so much to clinicians that joined us today, Helen and Jane, and also thank you very much to Emma for your experience and sharing everything with us today. And thank you to everyone who joined.